All right, officially recording and ready to go. So we'll just run through the Medicare 101. I've got a little different format today, so who knows how well this is going to work, but we'll definitely give it a shot. So today, and that's not working. Okay, come on. Why are we not? I should be plugged in. Damn it. Okay. Into this. There we go. All right. So we do our Medicare 101. Sorry for the small technical difference there out on recorded WebEx land. What today is look at the Medicare program in general, enrolling parts A and B and all that. So very, very basic. What is Medicare? It's health insurance for three types of people. I'm 65 or under 65 with certain disabilities. What are those disabilities? ALS, Lou Gehrig's disease, you automatically get here you could be 17 and 9 months get diagnosed with Lou Gehrig's disease, and the next month you have Medicare. Age with end-stage renal disease and people with disabilities. And it's administered by CMS. These sources that I want everyone to always have, use, know, pages, memories when you're doing Medicare. That's the federal 2015 Medicare Review booklet and the choosing a Medigap policy when we get to that portion. If you are on an appointment and you do not have these two materials with you, you are losing credibility and making your job harder. So when we get Medicare and the four parts, notice that there's Part A, hospital, Part B, medical, C, advantage, D, prescription drug. But what's up there that is missing to the casual observer? One in the studio audience? Medicare. Because not a part of Medicare. So when you're new to Medicare, people tend to lump med subs in, and they simply are not part of the federal Medicare program in the way this is presented. So I have a line down the middle, and if you notice over AB, it says that's original Medicare, managed by CMS. We'll take a look at the components and the deductibles and costs in a minute. And your Part C and your Part D, those are all offered by private companies who are contract to CMS to provide Medicare benefits. So how to enroll in Medicare? Well, number one is automatic. If I am turning 65 and I'm set up to receive my Social Security benefits or a railroad retiree, railroad retirement benefits, I'm automatically enrolled. I will get an initial mailing to me 3 months before the birth month that I turn 65. Or if I'm under 65 and I've been on Social Security disability, I will get it on my 25th month of disability benefits. One important note, occasionally run into people, agents that are trying to sell someone on SSDI. That's Social Security Disability Income. Now, the question is, what is the difference between traditional or conventional Social Security disability payments and SSDI where it comes to Medicare? Any blanks in the studio audience? The answer is this. I have paid in at least 40 quarters, years of withholding taxes, and I become disabled, and I apply and qualify for Social Security disability, then I get SSI, and I'm eligible for Medicare based on the fact that I paid at least 10 years into payroll taxes. SSDI, I get this all the time. They're drawing SSDI. They've been 3 years drawing it. They don't have Medicare. Can I sell them an Advantage plan? The answer is no. And reason being is if they're drawing SSDI, it's because they didn't work 10 years, 40 quarters benefit, and they are not eligible for Medicare NB based upon the disability. Sign into somebody with SSDI, and they're on 2 years, closing in on 24 months of disability, you do not have a Medicare prospect. Okay? So, if not drawing Social Security, I have to enroll myself. Okay? So, I'm drawing Social Security benefits. I'm turning 65. 3 months before my birth month that I turn 65, I'm going to get this package. And if I want my Medicare A and B, I just keep it. In cases, I may want to refuse Part B. In some cases, I may want to refuse Part A. So if I just sign it and send it back, or call Medicare if I do not want A. When it is not automatic, this would be for people who are laying their Social Security beyond age 65. This is very common these days, because the full return age of Social Security has been phased out beyond 65 over the last couple of years. It's not common to be talking to someone who won't collect Social Security full benefits until 66 and 6 months. It eventually goes out to 67. So there are many people who continue to work, either self-employed or through a company. So if I'm not drawing Social Security and I want my Medicare when I'm 65, I have to enroll myself. And I do that on the Social Security website, ssa.gov. I saw her do it. It took her 7 minutes online. Or in a Social Security office and apply online. And you do not have to be retired. This is our standard initial enrollment period grid, and this is how it refers to Medicare Parts A and B. So the month I turned 65 was August, as an example. Then 2 months before, I may enroll in Part B. So July, June, the beginning of May would be my 3 months out. I could enroll in Part B, and my coverage would start August 1. If I wait too long, then I still have time to enroll, but I'm in the delayed start period. So if I didn't know, and it's August 5th, and I need to sign up for Medicare A and B, because I talked to an agent, then I would sign up in the month of August, and my Medicare A and B would be effective 1st of September. They'd start, but I don't have any penalties, and so on and so forth until until my EP period expires. So this example, August, 1 after would be September, 2 months would be October, 3 months would be November. So if I just completely slipped my mind, didn't know, I would have until the end of November to enroll for a 12-1 effective date. And if it goes by, if I missed it, then I've got a problem. The general enrollment period, this occasionally runs into play, and I'm starting to see this more and more, especially with people working beyond age 65 and maybe getting a retirement reduction package from their employer. And the employer says, we're going to let you stay on the group health plan for 12 months, 18 months, even though you're being laid off. It's part of your service package, and they don't activate their B, and it just gets ugly. So in other words, if I go beyond that 7-month initial, I don't enroll in my B, and I do not have other insurance, and the key here is based upon my or my spouse's employment, I have to use the general enrollment period when I want to add my Part B. That's January 1 through March 31st is the time that I can sign up. I would go down to the Social Security office, fill out the paperwork, or I could do it online. There is coverage becomes effective July 1st. So even if I apply January 1 online, B does not become effective till the following July. So this is an example. Let's say you ran across a client on April 5th. Didn't have a valid enrollment period. They needed to use the general enrollment period to sign up. They didn't know it, and it was April 5th of 2015. The earliest they could sign up during during the general enrollment period would be January 1 of 2016, have on March 31st, they would get it all done, and then it wouldn't be effective till July 1 of 2016. I had to have that conversation with someone, a very sweet 70-plus-year-old woman that had not done Part B because of income reasons, thought she didn't need it. She was diagnosed with cancer, of all things. And in April, I had to tell her she was going to have to go 14 months without Part B coverage unless you get a sympathy exception from CMS. CMS determines these enrollment periods. The insurance company have no bearing whatsoever in this. And if there's a premium penalty, 10% for each full 12-month period eligible, but not enrolled, and you will have that as long as you have Part B. So it affects you if you have coverage. Okay. Part B, if it may affect you, you may want to delay enrolling. You have employer or union coverage, and here's the key word. You or spouse or family member, if you're disabled, is still working. Coverage, retiree coverage. I'm on layoff package from my employer, and they're extending benefits. Is not based upon your employment, and you have a 8-month clock that begins ticking. So your employment ends. You may special enrollment period to sign up for Part B without a penalty, and an 8-month period from when your coverage ends. Also, when you start and sign up for Part B of Medicare, or when your client does, that opens up their Medigap open enrollment period. And it's very important as agents to understand there's a Medigap open enrollment period, which means I can fill out a MedSup application within 6 months of my B date, and I don't have to answer health questions. I could be an amputee in a wheelchair, diabetes, heart failure, cancer, Parkinson's, county known to man, and I would be issued a MedSup with no pre-existing and so on. Don't confuse, especially when you're talking to clients, the Medigap open enrollment period with what we call the standard AEP or annual enrollment period for Advantage or Part D. The other thing to realize is that once someone activates their Part B, the enrollment period for MedSup starts, and it cannot be delayed, it cannot be repeated. After 6 months, it's over. They have to answer health questions to apply for the MedSup unless they have another guaranteed issue right, and we'll get into those in a moment. Look at the benefits of Part A. What is Part A? Part A is your hospital coverage. That's the brick and mortar of health care. In the for what it's worth trivial question, why Medicare have Part A and Part B? Because Congress is a great plagiarizer. In the 1960s, what was the most dominant health insurance that you could buy? Yes, Blue Cross and Blue Shield. Blue Cross and Blue Shield. Okay? What does Blue Cross mean? Blue Cross is hospital. Blue Shield is doctor. And so in the 60s, I wasn't alive then, but I was told you could buy coverage only, and buy medical or doctor coverage only, or you could combine both and have full coverage. And so Medicare was designed in the 60s by Congress. It's still in that model. That's why A is hospital, and B is your doctor and outpatient services. So Part A cover. Part A, as your brick and mortar, is your hospital room, a semi-private room. If somebody wants a private room, they will pay the cost difference. It includes your inpatient rehab, inpatient mental health care. There is a lifetime 190-day limit on inpatient mental care. Normally it's not a big deal. And generally all drugs provided during an inpatient stay are covered by your Part A. Skilled facility, again, semi-private room. Skilled nursing also means you've been in the hospital for at least 3.5 days. You are under the medical care of a doctor services are under B. Is a model on that. We're going to dive more deeper into that. Hospice care for the terminally ill, and of course, blood. So A only, that is all the coverage I have. Most people do not pay a tax for their Part A, and that is based upon having at least 10 years of payroll taxes into the FICA system. 3 quarters is sometimes said, but 10 years. If they paid FICA less than 10 years, they can get Part A, but they may have to pay a premium for it. And those amounts are in the Medicare. And you commonly where you see this is with immigrants, older immigrants coming to the country. They may only work for 5 or 6 years, and they may want to pay a premium for it. And you see the coverage for inpatient care. Benefit periods. This is a confusing part of Medicare because Medicare still uses benefit periods. It is the use of inpatient hospital skilled care and begins the day you first receive inpatient care, whether it's in a hospital or a SNF skilled nursing facility. And it ends when you've not been in the hospital or skilled nursing for 60 days in a row. So what does that mean? It means when I have original Medicare only, Part A, and I'm in the hospital, I pay my Part A deductible of $1,260, whether I'm there for 1 day or 5 days. I go out of the, if I'm discharged from the hospital on day 6, and 4 days later, I'm admitted to the hospital. Because there's less than 60 days separating the readmission, Medicare considers that readmission as a continuation of the first, and I'm not charged, whereas my Medicare supplement, if I have one, another $1,260 deductible. However, I'm in the hospital for 6 days, I go home on the 7th, and then 61 days later, I'm readmitted to the hospital. There is a new benefit period, and I do $1,260 deductible, and are no limit to the number of benefit periods a person can have. So dollar amounts, these are standard. The deductible for days 1 through 60 is $1,260. The day co-payment for days 61 through 90 is $315, and then 91 through 150, and so on and so forth. What's interesting about this is you don't see this very often in this day and age. A person could get to their days 61 through 90 and continuous. Because I go into the hospital for a week, say I have a major stroke, I'm in the hospital for 30 days. I'm discharged. Later I go back into the hospital for 5 days. Less than days, so I'm still in my first benefit period. As far as Medicare is concerned, I have my first 30 days. The 60 benefit period starts, still continuation. So now 5 days, Medicare is saying I'm in there 35 days. So conceivably, be in and out so much that I could get to over 60 days in a benefit period and have the $315 per day. Okay? As a point of trivia, if you want to know how Medicare calculates these, you know that the initial deductible, $1,260 is based upon Medicare number. The day 61 through 30, your life reserve is 1/2 of $1,260, and your day 61 is 1/2 of that. Interesting little trivia question, not that it really matters. And we will take ringer, it will not happen again. Skilled facility coverage. Again, many people, especially Lou, can tell you, they think, well, Medicare is going to cover my long-term care costs. It's strictly a therapy that's going to get you better, get you home. It's not long-term care custodial. You are required an inpatient stay of 3 consecutive days or longer, and you must be admitted to a skilled nursing facility, generally within 30 days, that is approved by Medicare and for your treated condition. What they cover for skilled nursing, ambulance transportation is very limited. If there's another way to transport you that is acceptable, then they will not pay for any. Let's just have you as a taxi. Here are deductibles for skilled nursing, days 1 through 20. Medicare pays it all. Days 21 through 100. The member or their supplement would pay the 157.50, and it's limited to 100 days in the benefit period. Care. I see this a lot, especially with Medicare Advantage, agents selling, oh look, you've got home health care in your Advantage plan. Please don't do that. Medicare Advantage is Medicare, and to qualify for home health care under Medicare's guidelines, you must be housebound. It means you need therapy, you're really not sick enough to be in a skilled nursing facility. You can go home, but you need the therapy to come to you, okay? It must be skilled care on a part-time or intermittent under the care doctor, a face-to-face encounter with the doctor first, and the home health care agency must be Medicare approved. It is very stringent. I've actually had cases where a lady was on home health care, her church friends felt bad for her being housebound. They loaded up the big van, a bunch of guys came and took her out of the house to get her out and go out to the park or something like that. Believe it or not, because she was able to leave the house, she was no longer housebound, and Medicare cut off her home health care benefits. Reviewed every 60 days, and in original Medicare, you pay generally nothing. 20% of the approved amount for durable medical equipment, oxygen, wheelchairs, walkers, that type of thing. Care, special care for the terminally ill, expected to live 6 months or less. I've had people who've been on hospice for 13, 14 months. You know, they may have eventually been expected 6 months or less, but you know what, it's how it is. 10-day periods and unlimited, 60-day period beyond that. The key here is on Medicare Advantage, if I'm Medicare Advantage and I qualify for hospice, Medicare takes over. Hospice bills will always go to original red, white, blue Medicare, even if that member's on an Advantage. It's the only time that Medicare pays. And here you see the various covered services for hospice. There is respite care for a caregiver and so on and so forth. I've never had anyone complain about hospice care ever. Cost, nothing generally, up to $5 for prescriptions for pain management. And I've not even had clients tell me they've been charged that in many cases. Blood, Medicare Part A, really doesn't matter. For my Part B services, my Part B that I pay a premium for are all of my outpatient or my doctor's services. There's a deductible that applies, and then after deductible, I pay the other 20% based upon the doctor, on the Medicare approved amount, and if doctor accepts the sign. So most procedures, you have the calendar year deductible, and then you would pay 20% after that. For your durable medical equipment, things like oxygen equipment and supplies, there is a new program called competitive bidding, depending on if the supplier. I've not gotten any feedback on that in the Kansas City, but in some cases, you have to go through in the bidding markets. If you don't use specific suppliers for your DME, you run into issues. Home services, again, is covered under Part B, and you have your other services, labs, kidney dialysis, diagnostic x-rays, testing, and so on and so forth. The Part B preventive services, and this is just Daryl's side note, but it's preventive, not preventative. So those of you that have seen Cars, and you know it was Mater, and he always used to say, just like tomato without the it's preventive, not preventative. So preventative without the But in there, and if you want more information on the wellness benefits, they are in your Medicare and You. We'll go back and take a couple pages to look in the Medicare and You booklet. They're not covered by A and B. Long-term care, routine dental, that's why we have standalone dental through Medicare or Security Life. Dentures, cosmetic surgery, acupuncture, hearing aids, that type of thing. In Medicare, I have in 2015 a $147 calendar year deductible. If I did in January, I don't have to meet it again throughout the rest of that calendar year to that 20%. Now, it's also key to understand that most people understand that Medicare pays far less than doctors bill. So, to use an example, if the doctor bills $1,000 for an outpatient, whatever, that bill might go to Medicare, and Medicare might say, you know what, we only think it's worth $300. So Medicare says that's the approved amount, the doctor's bill off of the approved, accepts the approved amount, Medicare pays their 80%, assuming the deductible is met, the client pays the other 20%, and the dip above the 300, nobody else. I see that a lot with newer agents. They get really confused about that. I get a lot with clients. They think that their med sup paid the difference between that 300 and what the doctor billed. Doesn't happen. Doesn't happen. Here's your IRMAs, and there will be handouts for people on this. An income-related Medicare adjustment, and this is throwing people a little bit. If you work with a financial advisor and you help them with their Medicare clients, or you want to start dialogue with Medicare, with financial advisors on how you can be a resource to their clientele and maybe get shared leads and what have you. If I'm working beyond age 65 and I'm making a pretty good income, it's not hard to see people making over $90,000, especially in southern Johnson County. You see my individual return, if I'm less than 85,000 single or 170,000 a husband and wife, you pay the standard rate. But if I go above those thresholds, then I have a higher premium for my Part B. So the conversation with the financial advisor would be, are you talking to your clients at age 61, 62 about how they are structuring their income so that they are eligible for Medicare and they want their A and B to be in effect? You don't have a client over one of these thresholds by a penny, $50, because he didn't move some discretionary income into a tax-deferred vehicle. Maybe they could defer compensation into a later year, take a different package, break it up, all those types of things. Because if you have a husband and wife who get a little something, all of a sudden they find themselves, instead of at $160,000 AGI, adjusted gross income on return, but it was $160,050. That cost them, their Part B is $272.70, let's say $270 versus $210 if they didn't have that extra $50 on their AGI. And for both, that's $20 a month times 12, that's $1,500 for $50 extra income. So it's a great way for the financial advisor to reopen a conversation and for you to be a resource and potentially be able to work with the Edward Jones guys or Ameriprise guys, all those types of people, and maybe develop some a working relationship. In southern Johnson County, I have enrolled a person who paid $336 for his Part B because he was making over $214,000 a year, single guy.
Okay.
Danielle, all right.
What did you say?
Probably single. Okay, so we pay our Part B premium. If I'm Social Security or railroad retirement, they'll take my benefit. Federal retirees can have it out of their federal benefit. I am not drawing Social Security, but I want my Medicare. Then I will get a quarterly bill for Medicare, or Medicare will allow me to set up direct deduction from my bank account. Part enrollment penalty. I didn't understand. I didn't activate my fee. I should have. I didn't have other coverage through my or my spouse's employment. And now I know I have 10% added for each full 12 months, and I can only sign up during the general enrollment period. If I have other coverage, employer group, then I can use an SEP, and usually So here's an example. Mary delayed signing up for Part B 2 full years after she was eligible. She will pay a 10% penalty for each full 12-month period, and it is added to her Part B premium. So in 2015, if she had 104.90 plus 20% for 2 full years, that's $20.98, 125.88, and Medicare rounds up, so she is paying $125.90. And in 2016, when the Part B premium goes up, which is expected to, or should it, then you would pay 20% of the increased premium. So it's always 20% or your penalty of the then current premium for Part B. We've got a question here. If you are under 65 and disabled, you automatically get Part A and or Part B after you receive Social Security disability benefits for how months? 24 answers B. B. Correct. Lou Limping. Okay. The Centers for Medicare and Medicaid Services is responsible for enrolling most people in Medicare. True or false? Lou, do not answer this question. This is a Danielle question.
B.
That is correct. Do you know why? Lucky guess. The reason it's false is because the Social Security Administration enrolls people into Medicare. People apply Medicare through the Social Security office or the Social Security website, not CMS. Okay. All right. So choices. We're going to take a look here. Original Medicare, Parts A and B. We'll take a look at private contracts, Medigap policies. We'll look at Part C plans. It says Part D, but I put that into a different presentation, so we'll see that at a different time. So what is original Medicare? Again, it's run by the federal government. It provides you your A and or your B. And only speaking, you can see any doctor or hospital that accepts Medicare. So an Advantage plan with networks, as long as that doctor is willing to bill red, white, and blue Medicare, they can see them. The client usually pay a premium for Part B. Most people do not pay for A. They have deductibles or copays. They get their summary notice, and they can join Part B plan to add drug coverage, but it's not in original Medicare. I touched on this. This is where the doctor says, you know what, regardless of if I bill $1,000 for a service, if Medicare says it's only worth $300, if I want to play in Medicare's sandbox and get federal money, I'm just going to take assignment. And most doctors and hospitals take assignment. I see agents sometimes selling med subs like a Plan F because it pays the excess charges. Whoop-de-doo. The doctors don't bill the excess because it costs them more than what they get, in my humble opinion. They all pretty much take assignment. And the claim is submitted directly to Medicare. Providers do not accept assignment. They can charge up to 15% more. It's called the limiting charge, and I don't see it very often. Some providers have no choice and must accept assignment. It's part of your rule when they sign a contract. Medicare Part B covered prescription drugs, oral chemotherapies, that type of thing are Part B, and the ambulance suppliers, because this was a big issue years past. So now it doesn't matter, the ambulance, the air ambulance, they have to accept Medicare assignment. Price tracks. You don't see this a whole lot, but you can see it from time to time, especially in Florida, where there actually has, they had one of these up in Omaha, a boutique concierge service. And you have a contract with XYZ doctor, and you paid $4,000, whatever per year up front. The doctor said, I'm only going to limit myself to 30, 40 patients, some ridiculous number like that. But if I'm collecting, money, okay. In cases, because they're not billing Medicare, it's a private contract with the member, there's nothing that they're going to do. So anyway, that's private health insurance. We'll talk about this a little bit more. Then we get open enrollment periods, so on and so forth. Medicare policies are all standardized, and you see the plans. And again, we're going to talk about this in a little different format down the road. But all med subs are the same. eligibility, premium. My most important consideration is future rate hikes. So Medicare Advantage plans work with another option approved by Medicare. If you don't have page 75 of your 2015 Medicare and you book highlighted, memorized, whatever, that is where you can show the client all the stuff that I'm saying up here. So I have to do that just for shits and giggles here. I'm pulling up my 2015 Medicare and You PDF. And go to page 75. And learn about Medicare Advantage. And so having the conversation with the client, this is one of the first I want to go to. And not because I'm so great and wonderful, but I want them to know this is the gut telling them. This isn't Daryl Russell. This isn't Lou Petrakis. What is your Advantage plan? It is another way to get your Medicare coverage. If you join a Medicare Advantage plan, what does it say? You still have Medicare. You pay hospital coverage and you're being medical from the Advantage plan, not original Medicare. Now, those of you who work with me know that when I sit with a client, I tell them, folks, if you choose Medicare Advantage, your Advantage card is your Medicare card. You take the white and blue card out of your billfold, out of your purse, keep it in a safe, keep it in a drawer somewhere home. And you go anywhere, and that provider wants to see your Medicare card. You only give them the Advantage card, period. So they're called Part C. They may have networks, so on and so forth. And again, fill in Medicare with all rights and protections. They get all A and B services. Medicare is what they call actuarially equivalent to original Medicare, which means they cover all the same services. Sometimes when you're in a client meeting, they're concerned that Medicare Advantage might not cover things, or they're going to have to take a physical and all this type of stuff. Medicare Advantage, because it's Medicare, being admitted by a private company, has to cover all the services, the cost sharing. The copays can be different, but they all the numbers for Medicare Advantage, and they put them in a big bag and shake them up. And here, when a carrier presents that plan to Medicare, it has to mean that if someone's on an Advantage plan, they could not be exposed to any more pocket they have under original Medicare. So that would mean actuarially equivalent. Again, I'm going into a deep dive on some stuff here, but the bottom line I need new agents to understand is when someone enrolls in Medicare Advantage, they do not in any way, shape, or form lose any Medicare benefits. Okay? The cost sharing in the networks may be different. And there's the different types, HMOs with appointed service option, PPO, special needs plans, private fee-for-service, and the MA or medical savings account, which we don't have in any area. All with Advantage, the member must continue to pay their Part B premium. There is no getting out of it. In Florida, in some markets, the Advantage plan may actually give them a Part B buyback. We've seen this, and I've had some clients that move from Florida up to KC, and the first thing they do is complain they have to pay for their Part B. So what is Part B buyback? Simply enough, an Advantage plan is getting so much money from Medicare in that county, instead of being a zero premium plan, no cost, just pay your Part B, it says, in effect, sign up for a Medicare Advantage plan, and we'll write you a check every month for $104.90 to reimburse you for paying your Part B. They sign up for an Advantage plan and they get paid to do it. Not as much because of the funding levels, but anyway, this is an aside there. We'll have MayPay, you have premium, you have all your different out-of-pockets, and we'll look at those down the road. Eligible for Advantage must live in the service area, be enrolled and maintain their Part A and B, and they cannot have end-stage Lou, define end-stage renal disease for me.
When somebody is on dialysis.
Incorrect. If I catch an agent saying dialysis is ESRD, you will penalty box. The true definition of end-stage renal disease is you have permanent kidney failure requiring dialysis. You are on a waiting list for an organ transplant. So end-stage renal disease means permanent kidney failure requiring dialysis. You are waiting a kidney transplant. If you tell someone dialysis, they can get dialysis for a number of reasons and not have ESRD. Dad was going through cancer treatment. He had kidney problems because of the chemo that he was taking. Receiving dialysis 3 times a week, but he was not on end-stage renal disease. Kidney functions later came back and he no longer required. So I actually had agents walk away from Medicare Advantage sales because someone was taking dialysis, but they did not have, as near as I could tell, end-stage renal disease. Okay. You can only be in one plan at a time. When someone Advantage and they switch to another Advantage plan, they're automatically disenrolled from the other plan. Can I join or switch Medicare Advantage plans? So I have my initial enrollment period 7 months before, just like Medicare A&B, begins the month of, 3 months before, the month, and so on and so forth. Hold just a moment. All right. So looking at, again, the Medicare Advantage enrollment period, it follows that same 7 months. So I have 3 months before I'm 65, the month up, or 3 months after, or that could be tied to a delayed Part B beyond age 65 as well. Plus I have the Medicare open enrollment period, October 15th to December 7th. Again, I gotta click here so I can advance. Okay. Special enrollment periods. There are a lot of special enrollment periods, but the most common one is move out of the planned service area. The Kansas City metro area, with all the different Advantage plans, it is beneficial to align oneself with realtors who work a lot with the sometimes you have SRS, seniors real estate specialists. They help people decide to move into smaller homes or condos and that type of thing. I was on a United Healthcare Medicare Advantage plan, and I lived in Johnson County. And for a reason, I decided to move to Wyandotte County. I had moved out of my Medicare Advantage plan's service area because United Healthcare does not service Wyandotte County. That client does have a SCP go into a different plan based upon those. Okay. So you need to be aware of the service area counties for all the different plans that we have. Some of the more common SCPs, and we'll have that greater discussion of that in a separate training program. 5-star plans, we don't have any here in Kansas City, but they have an open enrollment all throughout the years, SEP, and is 1 SEP per year to move into a 5-star plan. The MedAdvantage disenrollment period. This is on the AHIP, but it is exactly what it says. It is a Medicare Advantage disenrollment period. It's January 1, and it lasts through February 14th. My opinion, the reason this was created by Congress and enacted into CMS was because some people were being enrolled into Medicare Advantage plans during the annual enrollment period when they thought they were enrolling in a standalone prescription drug plan. And January 1 rolls around, they find out they have an advantage, and they were previously stuck unless they want to claim agent fraud and apply for an SEP. So this is there so that if little Sally Gray here on January 15th realizes her drug plan is not a drug plan, but it's a Medicare Advantage plan, she can easily disenroll. All she has to do is apply for standalone drug. The agent would code it MADP, Medicare Advantage disenrollment period, and then she is returned to original Medicare February 1, So what are types of Advantage plans? Medicare health plans, you have cost plans, we don't have any here, demonstration plans, we don't have any in the metro area, and then PACE, we also don't have any of those here in the area. What is a Medicare cost plan? Cost plan, I've run into these once when I lived in eastern Iowa. There was a plan called Dubuque Medicare Medical Associates Cost Plan. Medical Associates owns the hospital in Dubuque and several doctor clinics. They start their own Medicare Advantage as a cost plan. And a cost plan is kind of like a Medicare Advantage chameleon. And what I that is when I go to see providers that are part of the network, I present my Advantage card and I pay Advantage plan cost sharing. But if I go to a doctor who's not in the Medicare cost plan network, then I actually show my red, white, blue Medicare card, and I do Medicare, red, white, blue Medicare cost sharing. It's a chameleon. It changes its colors, if you will, the provider you see. And if you have any here, but occasionally you get a client that may ask you, what's a cost plan? I read about it in the book or what have you. So we have knowledge check. Which of the following is not a type of Medicare Advantage plan? Jane would like to answer our question here. Is it A, B, C, or D? Which of them is not a type of Medicare Advantage plan? There you go. Easy. Do I get a free cup of coffee? You get a free cup of coffee. Okay. If you do not have a prescription drug coverage that is at least as good as Medicare drug coverage and don't join a plan when first eligible, what is the penalty per month when you join at a later date? I deleted these slides because we're going to talk about this in another section. But Lou, if you'd like to answer, I see you chomping at the bit. C. C. For each month you could have appeals and grievances. The training on Medicare Advantage is you are supposed to talk to people about their appeals and grievances. Sometimes people think that's just about Medicare Advantage. No, it applies to original Medicare as well. So in other words, if a client has red, white, blue Medicare and they don't think the doctor should have paid better or whatever, there is an appeal process for that. So guaranteed rights in Medicare, guaranteed rights in original Medicare, guaranteed rights in Medicare Advantage and Medicare health plans. Why? Because it's all Medicare. That is one thing I like to beat into people's heads. When you are enrolling a client into Medicare Advantage plan or a Medicare Part D standalone, you are not selling them insurance. You are enrolling them in a Medicare federal government entitlement program, and now they have guaranteed rights, even though it's a private company. The private company is contracted with CMS and has to follow their rules. So we'll talk a little bit more about treatment choices, appeals, complaints. Complaint is a grievance, quality of service, care that is received. Common grievance might be, I call the doctor, and whether I have Medicare alone or I have a Medicare Advantage plan, the doctor says, well, based on your Medicare coverage, I can't see you for 3 weeks. I'm too full, I have other clients ahead of you. The client filed a grievance with Medicare, or if that was an Advantage plan, they would file a grievance with their Medicare Advantage plan and say, hey, this doctor refused to treat me, you need to do something about it. Or they give their explanation of benefits, and they think cost sharing should have been less. Had a case with a client the other day, came in, we were talking about outpatient services for his wife who was going to enroll in an Advantage plan. I used cataracts as an example. The guy's like, well, wait a minute, I just had that done 3 weeks ago and I had to pay $2,000 up front. No. Let's go back first. Let's call the carrier, make sure the carrier actually got the bill. But, and it got the care, the doctor never billed the plan. So then, that was more of a grievance against the doctor. Where it would be an appeal would be the carrier denied coverage, said you don't qualify based on Medicare criteria, or they inaccurately billed the plan and the guy's expecting a $200 copay and he gets I think Again, Medicare summary notice explains why Medicare didn't pay, how to appeal, where to file your appeal, how long you have, and so on and so forth. Always keep those copies of appeal documents. So Medicare supplement or Medigap rights and original Medicare. You right to buy a Medigap policy with guaranteed issue in certain situations. In Medigap open enrollment period, companies cannot deny coverage, place conditions on coverage, charge more, have pre-existing, or have a 6-month waiting period. Okay? This is covered in the Medicare supplement book. It's also in your Medicare and You. So if I flip over here to Medicare and You, and I look at if I go on to I have my page number memorized just yet. I think it's 92. So this is in the Medicare and You, page 91. Talks about med subs a little bit. You can share this with your client. Page 94. It's what should I know about med subs, and it does talk here at the bottom of this page for the client to buy. The best buy Medigap policies during your Medigap open enrollment period, 6 months period before, after, and so on and so forth. So you have resources, and the reason going back to the Medicare News, I want people to understand that's how you look like a subject matter expert to your client, because telling them, you show them where the Medicare program tells them these things. The grievance process, so on and so forth, right to request coverage determination, and this flow chart of the Medicare appeals process. So we've got knowledge question. You have repeat rights, you being the beneficiary, in A, B, C, or D. Would anyone like to answer the question? Lou, the answer is D. D. All of the above. Why? Because the federal government carries a big stick. It's called a purse. What? A purse. A purse. Oh. There's so much money in the Medicare program that if I'm a Medicare Advantage plan or I am an Advantage Party plan, if I want to play in Medicare Sandbox and collect all those dollars, I have to agree that that client, that member that joins, will have all those guaranteed rights. So appeal. A, B, C, or D. B. The correct answer is B. A coverage and or payment decision. So if they declined coverage, no, you shouldn't have, or they paid the claim, but they didn't pay what I thought they should have, or they made me pay more. So that's why an appeal is related to coverage and or payment decisions. We'll look at extra help, Medicaid, Medicaid savings programs. So what is extra help? Extra help sometimes is called LIS, low income subsidy. I typically train agents to use the phrase extra help. Why? Because all of the material client might get in the mail at their home, or if they're looking through the Medicare booklets or other Medicare publications, they just use the term extra help. If you go to the Social Security website, which is where you apply for extra help, low income subsidy, that's what they call it, extra help. Okay. So it's based to help people pay for their prescription drug costs. And if you have lowest income, you will pay no premiums or deductibles and small or no co-payments on their Part D drug costs. Slightly higher income, they might have others, and of course it can eliminate the coverage gap or a late enrollment penalty for Part D if someone qualifies for extra help. So these are all little things that if you understand these and become more of a subject matter expert, can help with your grassroots marketing, because you can go to the church groups, you can go to the inner city community centers, other community action organizations. Salvation Armies are wonderful places to go because they're always looking for outreach for the poor. Okay, you can talk about, can I do a talk on extra health programs, hour points, we can do that, and they'll drag in all the poor people you want. Now, would I want to do that during August, September, when I'm getting ready for AEP? Probably not. But when I potentially do that in February, March, April, when I possibly get from the people I could help with a little extra help, give them that subsidy, and then what happens when I get extra help? That grants me a lifetime or a continuous SEP, and I can change my Medicare plan anytime I want based upon qualifying for extra help. The SEP is, for extra help. So if I someone get on to extra help and have Medicare and a Part D plan only, I then go to them and say, gee, since you didn't know about extra help, and I'm glad I was able to get this put together for you, what else don't you know about your Medicare plan? Maybe you should review what you have to make sure you have a plan that's suitable for you. Would they be agreeable to that if you just saved them money, eliminated a coverage gap, maybe got rid of the late enrollment penalty? Sure they would.
Yes.
Could you then around and maybe find an Advantage plan that might be a better fit for them and make a commission in regards to doing everything else that you did for free? Absolutely. So for extra help, some people automatically qualify for extra help. So if they apply for Medicaid and they get Medicaid coverage, whether it's Slim B, meaning Medicaid is paying their Part B premium, or they get full benefits, they are automatically enrolled in the extra help program. That's why when someone's talking, I get calls from agents. These people they're on Part D plan, and the book says they should be paying $6 for their generic drugs, but they're telling me they're only paying $1.15. That tells me that person, because that $1.15 is copay amount tied to extra help qualifying. Okay? If that person has an SEP, you can change them any time of the year if you have a more appropriate plan. Of course, other things that you see up there. So what is Medicaid? Medicaid is low-income assistance for people with limited incomes. So you cannot have people that are Medicaid only and not Medicare. You have people who apply for Medicare and then because of their income qualify for Medicaid. And it's different by different states. Every state may have different names for it. Like in Missouri, it's MoHealthNet. In Kansas, it's usually called CanCare or Sunflower and all that type of thing. It's always different. Federal dollars, but managed by the states. That's why it's different in all the states. So if I come from Medicaid paying Medicare costs, they have the different levels. You see programs include qualified Medicare beneficiary. QMB, you'll hear me say QMB. I'm talking about a QMB. Qualified Medicare beneficiary, what that means is my income is so low that Medicaid pays my Part B premium for me, and as soon as I see a doctor who bills Medicare and that state's Medicaid program, Medicaid pays my deductibles and my 20% of original Medicare. I basically, as long as seeing Medicaid providers, Medicaid, for lack of a better term, is my Plan F supplement. I don't pay anything, okay? And I get the highest level of extra help on my drugs, and I'm only paying $1.15 for generics, $6.60 brands, and some of the, or $2 something for brand and what have you. You have specified low-income Medicare beneficiaries. Sometimes you hear me say SLMB, SLMB. It means that Medicaid pays my Part B premium, but they do. And these people generally are on a spend down. So that's to hear the people, oh, they've got this $25 a month spend down or $800 a month spend down. It can be a broad range like that. So these people are still responsible for their co-pays and their co-insurance of original Medicare. Okay? You can sell someone who's on a SLMB a Medicare Advantage plan if the co-pays are more favorable for them and the provider network and all that type of stuff. I get calls from agents, they're confused because someone be on a spend down, they're a slim B, but Medicare member tells the agent, oh, I don't pay any copays, I don't pay any Medicare deductibles. And what's happening is that may very well be correct, not because they're not responsible, but the provider is saying, you know what, I got somebody who's making a little over $1,000 a month. I bill them these 20% of these deductibles with Medicare, and chances of me getting paid are slim to none, and slim walked out the door. So the provider just eats it and says, you know what, we'll spend good money trying to get more money I ain't going to collect. I just increased my loss by billing for it. Qualified individuals and QDI, you don't see a whole lot of those in terms of Medicare. Medicare is a program for the U.S., so it only covers U.S. and U.S. territories. You see those listed there. That's why if your people want outside coverage, I'm going to Greece, I'm going to Tahiti, I'm going to Belize, whatever. Very limited emergency benefits in a MedSup plan. Some of the Advantage has limited benefits for emergencies. If they're really worried about it, tell them to go to AAA and buy travel insurance or when they're out of the country. And just don't even jack with it. Okay, here in the marketplace. I saw more last year, not so much now, but this is very much bears paying attention to. When I say marketplace, we're talking about the federal exchanges for health insurance as part of Obamacare. And when your people understand that if they're on Medicare, they cannot participate and don't need to participate in an Obamacare policy. And more importantly, they have to go sign up for Obamacare policies to avoid a penalty. Medicare doesn't change anything and all that type of stuff, so you don't need to worry about it. And you see that bullet point at the bottom. It is against the law for someone who knows you have Medicare to sell you a marketplace plan or ACA policy. Any people with minimum essential are covered, don't have to pay a fee, so Medicare Part A is considered minimum essential coverage. That's why they don't need Obamacare policies. So a little bit more about the marketplace. You can get a marketplace plan before your Medicare coverage begins. So let's say I lose my job and I'm 63 years old. Okay, they would apply for a Obamacare policy or ACA. So they kill that plan when their Medicare coverage starts, or they can keep the plan, but once their Part A coverage starts, they won't be able to get lower costs. Bottom line is, if you run into someone, and we're going to start seeing this now, they've been on a Obamacare policy for the last couple of years now, they're coming up on Medicare, the client needs to cancel Obamacare policy effective when their Medicare A and B are effective. And when Medicare A and B does not automatically cancel their ACA policy.
Are there policies automatically canceled when they reach age?
You're asking me why the government did something. I can't answer that question. I can only tell you it is what it is.
You all said you know everything.
Well, you know. Okay, let's keep on recording this. So knowledge health, what is Extra Health? Extra Health is a program that helps pay Medicare A, B, C, or D. What is the answer?
B, yeah. Party premiums.
Extra Health is a program that helps pay Medicare prescription drug costs. Medicaid application process and benefits are the same in each state. Oh, absolutely. That's why it's so convoluted and people hate it. Basics and resources and so on and so forth. This is an index. We've got this in a booklet that all the agents will get, but this is just for your information. How do I know what these income limits are? Well, income is 150% or below 150% of the federal poverty level, or here's the number to translate, $1,458 per month for an individual, $1,966 per month for a married burial money doesn't count, 401k money doesn't count the home that they live in. Here are resources on Medicaid. So these are federal guidelines. So if I make less than $993 a month and I'm an individual, single person, I should be able to qualify for QMB status, QMB, and Medicaid pays my Part A and Part B premiums, my other cost sharing, so that pays everything. If here's my income limit there, $1,331. Sweet, specified limited Medicare beneficiary. I make a little bit too much more money, so I don't get all my deductibles and co-insurance, but I do get my Part B paid, and here's for qualified individuals and some of the others there. But the more common ones are QMB and SMB. So that's our basic Medicare, understanding Medicare. We'll take a quick break while I shift some audio and video equipment. All right, so we started recording again on the WebEx. So here we have our training program on Medicare prescription drug costs. I brought it this way because this is probably the more confusing part of all this stuff, and I wanted to keep people into a deep dive here. Why are we not advancing? There we go. So what we'll look at is differentiate Medicare A and B from Part D drug coverage, because there are some covered drugs under Medicare Part A and B. We'll take a look at that. Talk about eligibility. We'll look again a little bit of extra health and kind of break that out. So the four parts of Medicare and prescription drug coverage, because again there is some under A and B. So we've seen before, we'll skip over. So Medicare prescription drug coverage depends on medical necessity, healthcare setting, medication, like someone who needs it for cancer. So there are times that prescription drugs can be covered under Part A and or Part B. This information applies to original Medicare. So Part A generally pays for all drugs during a covered inpatient stay. So in the hospital, and I'm receiving prescriptions, it's not billed to my Part D plan, it's billed to Part A of Medicare because I'm inpatient hospitalized. Then you have some for drugs in the hospice situation. B drugs. It covers limited outpatient drugs, injectables and infusible drugs given as part of doctor's services. Drugs and biologicals, things used for the treatment of end-stage renal disease. Used at home with some types of Part B covered services. Nebulizers, infusion pumps, okay? Some drugs with special treatments like certain oral anti-cancer, anti-anemia drugs, immunosuppressive drugs. I've had a transplant. I take rejection drugs for my transplant. Those are actually billed under Part B, like boy, of the Medicare program. Also covers certain immunizations like my flu shot, pneumonia shot, hepatitis, and cover certain vaccines after exposure to an illness or injury. And the example here is given a tetanus shot. That's all billed to Part B, like boy of Medicare. Part does not cover self-administered drugs in a hospital outpatient setting unless needed for hospital services. So old in Part D, drugs may be covered if not admitted to hospital, and in some cases I may have to pay and submit for reimbursement. This happens sometimes with Zostervax, the shingles vaccine, because it's billed under Part D, even though it may be administered in a doctor's office, and it drives people crazy. Knowledge check. Prescription drugs may be covered by which of the following? Part A, Part B, Part D, or D, all of the above? No. All of the above. Part A covers all drugs for people receiving Medicare-covered hospice care. Okay. Keyword all. Covers pain relief drugs are billed under hospice. You could potentially have someone under hospice taking an antibiotic infection or something like that. That's going to be billed under their Part D plan typically, because hospice is only Part of our drugs for hospice are pain relief, symptom management. Also take a look at drug plan, drug benefit cost, prescription drug plans. These are again approved by Medicare, run by private companies. Everyone who's eligible is available to everyone here. And what are the two ways I get Part D? A standard plan, or I buy a Medicare health plan, Medicare Advantage plan that has the drug coverage built in. The drug can be flexible, and that's why you see all these different plans with different levels of copays and different deductibles amongst the different carriers. So they can do all kinds of different stuff if they want. There is a minimum standard, so they have to at least offer the standard level, and we'll take a look at that. 2015, most people with at least the standard have a monthly premium, a yearly calendar year deductible, co-payments or co-insurance, and in the coverage gap, 45% coverage for brand name drugs, 65% for covered generics in the gap, and very little spending after the troop or the $4,700 out of pocket. So you see the standard structure for Medicare Part D, and you also find this same thing in the Medicare and U booklet. So here on page 103 of the Medicare and U, I'm seeing that same type of thing I have on the slide. So you can use your Medicare and U booklet to help people when you're doing a client interview on Medicare coverage limits. So what I'm saying here is in a standard benefit, and keep in mind that a Medicare Advantage plan that you're offering that has Part D drugs built in, or a standalone prescription plan, have better benefits than this. But this is what they call the standard design. In a calendar year starting January 1, Mrs. Smith or Sally here, my favorite fictional Medicare person, a $320 deductible. Once that's satisfied, then she pays a co-payment or a co-insurance until total drug spend reaches $2,960. So she paid the $320 deductible out of pocket, it's towards her $2,960. If she go over $2,960 in total drug costs, what she pays out of pocket, what the plan pays combined, then go to the coverage gap. And in the coverage gap, she would pay 45% of the cost for covered brand name medicines and possibly a dispensing fee, $2 and 65% of the plan's cost for covered generic drugs. What she pays and the discount paid by the drug company is out-of-pocket spending and helps get her out of the coverage gap. Should you reach $4,700, the truth that the total cost here, even though she was getting some help, and her out-of-pocket here, she goes into the catastrophic and pays a smaller amount. Now, the best way I've found to help agents explain backwards, upside down Greek, that is Part D and the spending amounts, is this example. When you go on a Part D plan, the best way to help you understand this is, let's say that Medicare gives you a checkbook that you can use for your prescription drugs throughout the year. And in that book, they deposit $2,960. As long as you have money in the checkbook, you can use it. So what does it mean? It means if your plan has a deductible of $320, and you on January 5th, and you get 2 prescriptions, and the total cost is $400. Well, pay your $320 deductible, and it's now satisfied, but writing it out of that checkbook. So instead of $2,960, you have $2,960 minus $320, or you have $2,680 left in your checkbook. So now the insurance company pays the other part, and you write your copay or your co-insurance out of that checkbook. So if your math is real good. People are always real concerned about, am I gonna run into the coverage gap of the donut hole? If I take 2,960 and divide it by 12 months in a year, it comes close to $250 every month in total drug costs. In other words, if you have a client who takes 3 generics for high blood pressure, they take lisinopril, they take, by the time I can spit out blood pressure medicine, and they take a little metformin and glucophage because they got a little oral diabetic medicines that they take, and between all 4 of their generics, even if they didn't have coverage, it'd be $100. Well, they're never going to go over $250 in total costs every month, so they'll never use up their coverage gap, their checkbook. So when you have a client that says, oh yeah, I take glucophage, I take a Novolog Flex pen, and I also take injectable insulin, and I take Advair breathing disc because I have breathing problems. I can see you those drugs are probably have a total drug spend of close to $600 a month, using that as an example. So they would use up their checkbook, $3,000, $600 every month. They'd probably use it up by the end of June. And it's a good way for you to help people understand how to prepare for the coverage gap. But then more importantly, the average Medicare beneficiary who doesn't take very much medicine or maybe takes one expensive brand name and a couple of generics, helping them understand their total drug cost, what they pay in copays or deductible if they have a plan with a deductible, and what the care pays combined have to exceed the $2,960. Okay? Now, coverage gap. The coverage gap is getting small. It could be that you paid 100% of your drugs, but part of the Obamacare Affordable Care Act, they changed this. You see the gap here is shrinking. In 2016, it's still 45% for brand name, but the coverage generic decreases. And we'll get to the point that come the year 2020, if someone does, a Medicare beneficiary does use up their initial limit of the $2,960, and that change every year too, then they would pay 25% of the cost of their drugs in the coverage gap. The plan would pay the other 75%. So you can let your clients know that we're just talking a few 5 years out, that coverage gap would be completely eliminated. So the extras that count towards your true out-of-pocket, that $4,700 amount in 2015, after your threshold you get catastrophic, and if you transfer plans, your troops switch with you. So people that are on extra help that switch plans, their coverage spending switches with them. So what counts towards my true out-of-pocket? Payment made by you, so payments from my medical savings account, even if I took money out for that. If a family member or friend pays my deductible, it counts. Qualified state pharmacy assistance programs in the state of Missouri, we have Missouri RX. If they're paying part of my drug cost, those amounts they're paying help satisfy my truth. If I make yours extra help, that counts. Indian Health Services, Motor drug manufacturers discounts, and AIDS drug assistance programs, ADAPS. I have one client who gets assistance from an AIDS drug assistance program. That don't count towards the truth. The amount paid by Medicare drug plan, the monthly drug premium, drugs purchased outside the U.S., not covered by the plan, so on and so forth. Part B, IRMAs. So we talked earlier about the income-related Medicare adjustment on my Part B. Boy, it's the same thing on drugs, and it's always a 2-year look back. And you are required to pay if you have Part B coverage. Failure to pay results in disenrollment from the Part D plan. So here's a chart. So if I am on Medicare with A and B, and I sign up for a D plan, and in 2015 I'm retired, and all I'm doing is drawing Social Security, maybe a little bit of pension, maybe I've got what other income sources coming in. Back, they being Medicare to what my adjusted gross income was in the 2013 filing year. So if years ago, I was making $125,000 a year adjusted gross income. And I'm single, that's above 107,000, below 160. So this tells me is YPP, your land premium, plus a $30.80 IRMA. So what does it mean? It means I decide I want to sign up for a zero premium Part D Medicare Advantage plan. A higher cost for Part B of Medicare because my income are higher. They use these same charts. And my zero premium Part D plan or Medicare Advantage, I'm going to get a bill from, let's say I sign up for a Coventry zero premium Medicare Advantage plan. Coventry send me a bill for the $31.80. Now, is that client going to pick up the phone and call you as his writing agent and say, you sold me a zero premium plan, you misrepresented it to me, I'm getting charged $32, I want your head on a plate? Absolutely. You need to be paying attention to your buzz. Now, if we're in a trailer park down in Harrisonville, something like that, is it really necessary for me to spend a lot of time talking about apartments? Probably not. If I'm in a $400,000 home in Falcon Crest in Lenexa, or if I'm up in Briarcliff of North Kansas City, or if I'm in Leawood in a $1 million home, on a horse, and the cart is like a Model T with air conditioning, should I probably be talking to the client about IRMAs? Absolutely. Because you differentiate yourself from other agents, and your client has better confidence, you know what you're talking about. And is this an opportunity to network with financial advisors, the marriage guys, MetLife financial advisors, all those people say, look, are you building this into your practice on how you prepare your clients? We're 62 and 63 have another discussion about let's make sure you don't overpay for Medicare based upon $500, $1,000, $5,000 of discretionary income that we could do things with the magic wand and move that money around in different ways. And keep in mind, IRMAs are always 2-year look back. Okay, so it's 2015. Based on the 2013 return. On January 1, it's going to be based on the 2014. Okay. All right, we've got a knowledge question.
They get it twice there.
Yeah, if I have high income,
Part D.
bingo. The question was, will they get twice? And absolutely. If I'm above one threshold for Part B, I'm going to be above the other threshold for D. So I'm going to pay higher premium for my Part B premium and higher premium for my Part D.
And married double it.
And married it per belly button. You got it. So, if the coverage gap improvements are reached in the year 2020, what will someone pay for their coverage of generic and brand name drugs? Yes, Lou, CC. CC, senor. Okay, Part A of Medicare covers flu vaccines. All covered under Part B like boy. So drug coverage, access to covered drugs, non-covered drugs, medication therapy management. So is a Part D covered drug. It must be approved by the FDA, used and sold in the U.S., medically accepted indication. Biologicals, all supplies associated with injection of insulin. Plus cover a range of drugs in each category. This can be a critical question for a client or new agent to understand. Drug formularies, which we're going to get into in a minute, are separated by what's called a therapeutic class of medicine. Okay? So, for example, statins are a therapeutic category of drugs. It's for control of high cholesterol. Every therapeutic category, every formulary has to cover each therapeutic and by Medicare rule on Part D, every form has to have
have at least 2 drugs for every type of therapeutic category. So no matter what the Part D plan is, standalone or built into Medicare Advantage, there is going to be at least 2 covered drugs for a therapeutic quality. Coverage, all drugs in 6 protected categories. So all drugs for cancer, HIV, antidepressants, antipsychotics, convulsives, immunosuppressants. So the formulas are not going to be different from one Part D plan to the other in these. And then all commercially available vaccines, except those under Part B, flu shots. Drugs excluded by a law under Medicare. Okay? Anorexia, weight loss, weight gain, ED drugs. Get this question. Believe it or not, in 2006, when Part B first became effective, Viagra type drugs were covered, lasted for 1 year. They took them out. See the rest of them up there. You'll see this a lot, people getting upset, Medicare members, because their prescription vitamins are excluded under a Part D. See Niaspan, and somebody saying, I like Niaspan. That prescription iron pill. You're not going to find it in any Part D plan. Don't have yourself crazy looking for it, because it's excluded by law. Okay? Again, this is more for newer agents, but you have tiers. So you have tier 1, 2, 3, or 4, plus co-payment, medium, so on and so forth, and you can see the screen. Changes. Plan may only change categories and classes at the beginning of each plan year. So your salary is good year to year. The only time the plan can take drugs out is give us 60 days notice before changes, and that is if it was withdrawn from the market by the FDA or manufacturer. How plans manage access to drugs. This is something that we're supposed to go over with the client at the time of sale. They can be shocked, they look at these things. But you need to understand, what does prior authorization mean? When you're looking through a formulary for Part D drugs, a lot of times it'll be, if prior authorization applies, you'll see the code PA. So the doctor must contact the plan to getting the prescription, so that way it's approved and it goes through. Step therapy. I like this one, rather than reading what's on the board there, it's just real simple. If your doctor prescribes the most expensive medicine in that therapeutic category, and that drug is labeled step therapy in the formulary, then the plan has the right to ask you to try less expensive medicines first. If that doesn't work, then just like a stair steps, well, we'll take you to the next level. And if that doesn't work, then we'll take you to where, and if need be, you end up at the most expensive drug. Yes? Is that something that somebody has to requalify for if they switch companies during AEP and another doctor has doctors?
Great question. I was getting there too. So if I've been through step therapy with brand X Part D, and I change to a different Advantage plan at the annual enrollment period, or an SEP if I move, I do not have to re-go through that. My doctor would simply send in a statement to the plan saying, look, Sal's been through step therapy with brand X 6 months ago, here's all the documentation, and she does not have to go through it again with the new plan. Okay?
Now, this would be an agent who's already gone through this on a pre-65?
Possibly.
They would have to document that they had tried.
Possibly. Where it applies set in stone, is I'm already on a Part D plan. I've gone through step therapy with my previous Part D plan, whether it was standalone or built into an Advantage. But now switching from brand X to brand Y. In that, I can guarantee you they do have to go through it again. Under 65, I'm on a different formulary. It's not Part D coverage before. It's under 65. You don't have to, but I always like to undersell
have to, and then have come back to bite us in the ass. So I say if they're under 65 on commercial, they shouldn't have to, but it's a possibility that they might because it's not Part D to Part D. Okay? So calendar year final rule on prescription drugs. Prescribers of Part D drugs must be enrolled in approved study or have a valid opt-out. The May 1, 2015 for final changed here. Prescription changes. You get updated formulary information from your plan's website, customer service center, give your doctor a code, give the plan's formulary. Why tell the customer to give the doctor a copy of their formulary?
Well, we can pick one that's gonna be.
Pick one that's going to be covered. If your client goes into the doctor with a Part D plan, they don't know. It's a nice little thing to say. Okay? You get a new drug. Let's say there's a new drug that's not on the plan's formulary. Okay? They can request an exemption from the plan, but it's not guaranteed. So if it's not on the formulary, they can put an exception request, but it's not guaranteed. Medicare therapy management, MTM. Sometimes you'll see this in the materials. What does it all mean? It means a pharmacist or other health professional does a comprehensive review of all your medications and talk to you about how to get the most benefits, any concerns you have, all that type of stuff, so on and so forth. Drug plan, your Part D plan may enroll you in medication therapy if you meet these conditions. One, for chronic health, you take several medications, your drugs go over $3,017 per year. So here's a lot, especially with Drug Improvement Plus and the SNPs plans. They talk a lot about the prescription drug interview that the clients get, and so on and so forth. That's all part of medication. So we're going to have a knowledge check. Prescribers must blank or blank to buy Part D drugs starting December 1, 2015. So the doctor must enroll here and be in good standing. Well, there is A and C. Enroll here and be in good standing, or enroll in Medicaid and be in good standing. Which of the following is not a condition for a Part D plan to enroll a person in medication therapy management? Paying attention, living alone.
Yeah.
Because the others are, I have one or more chronic conditions, I take several medications, and medications have a combined cost of more than $3,017. Don't worry about the medication therapy management so much because it doesn't come up very often, but you could ask there from time to time. And more importantly, it's in the Medicare review booklet you can pull out. Eligibility for Part D. I must have Part A and or B. I do not have to have both. I could join in a standalone prescription drug plan, or I could get it built into my Medicare Advantage. I have Medicare A and B to join in a Medicare Advantage plan, but again, if I just get it standalone, I only need A only. You must plan service area, and I like that. You can't be incarcerated, you can't be unlawfully present in the United States. So illegal aliens cannot get a Part D plan.
How do the Republicans get that?
I don't know. Of course, people must join a drug plan. Credible drug coverage. What does that mean? Current or past prescription drug coverage. So our group health plans are generally considered credible. Retirement plans, VA, TRICARE, Indian Health Services, and FEHB or Federal Employee Health Benefits. Credible means the plan that they had pays on average as much or more than Medicare standard drug coverage. How do the Medicare members know that their other coverage is credible?
Their plan's supposed to inform them.
They're required every year to send a letter letting them know that their drug coverage is credible, it meets or exceeds. Without credible drug coverage, the pay a late enrollment if they're eligible for Part D and didn't sign up, okay? It's important to kind of understand these things. So I have a gentleman with, they've got someone, they're on Medicare, but they served in the military, they're eligible for VA benefits. Drug coverage is credible. They technically do not ever need to enroll in a Part D plan. They go 5 years, 6 years, 10 years, and they decide they want to join a Medicare Advantage that has Part D built in. They do not have a late enrollment penalty for Part D because VA is considered credible. So let's talk about that for a little bit. Why would someone who's on VA want to buy a standalone Part D or maybe want to have a Medicare Advantage plan with Part D drugs built in?
It's not feasible or convenient or practical for them to go to the VA anymore to be seen.
Here's what I like to use when I'm helping an agent and we're talking to a peer member who has VA. First of all, like Mr. Client, thank you for your service. Okay? And you've got phenomenal benefits to the VA. The administration drug benefit is very well run, guys. It works like a champ. They get mail order, all that type of stuff. What you have to understand is that to get their scripts, they have to go to VA, and script has to be written by a VA doctor. If I go see Dr. Jones, my family doctor, and he writes a script, he can't call it in. I have to, as a veteran, I have to go to a VA facility, have one of their docs agree to rewrite the script, and turn it in. Well, for my main medications that I'm taking every month for my blood pressure, my cholesterol, or my insulin, great, no big deal. I get that done once. It comes to me in the mail order once a year, once every 6 months, however it is. I go see somebody, they renew the script. Beautiful. I paid $9 for a month for mail order on brand drugs through VA. You can't beat that with a stick. But Mr. Veteran, a lot of other veterans like a Medicare Advantage plan with the Part D drug built in. Number one, let's assume that you get diagnosed with, you wake up and you just feel terrible. And you're like, well, I could go to the VA hospital and, get coverage. You call them up like, well, what's wrong? Something's wrong. I don't know what. It's not, are you puking? No, I just, whatever. Well, get you in, but it'll be a week from tomorrow. Well, if you're Advantage plan, you call your doctor. You're going to have your $5 or $10 copay, whatever it is, and maybe they can get to see you that day. Okay, you go to an urgent care clinic and you pay the $40 copay, all that type of thing. It says you got a case of a little bit of an infection going on. Here's a 20-day prescription for some antibiotic. You feel terrible. Just driven yourself to the urgent care clinic because it's 5 minutes from home, and doctor's telling you you need this 20-day supply of an antibiotic. And you go to Greens and they say it's $200 for that 20-day supply because it's a high-power antibiotic. And you're going, damn it, do you want to get a car, drive up to Leavenworth, have a doctor rewrite the script, or if you have that Part D plan built into your Advantage plan, how convenient is it to, on the way home, stop by Walgreens, your Part D card, pay whatever co-payment, and go home, and within 10 minutes, be in bed, covered up, doing whatever, and be done with it. That's why a lot of veterans like the Part D built into their Advantage plan or standalone. As you already know, Mr. Veteran, one program cannot bill another. So Medicare doesn't bill VA, VA doesn't bill Medicare. So when you have veterans drug benefits and a Part D plan, use one or you can't use them both. So the guys that join these plans, they use VA for other medications on that therapy, their regular mail order medications, And for the occasional, oops, I got a little infection, oops, I need this. They live convenience and know they can go to Walgreens, Walmart, Kmart, Hy-Vee, whatever, show the Part D card, pay the copayment, and just go on and not always have to go and spend a day, all day type of thing. Yep, makes sense to me. Well, do you want the zero premium plan or do you want the $29 plan? Give me zero premium. Great. I'll do paperwork for you. I just need to see your wife with a Medicare card, and I'll hang on while you go get that. What does the client do? Starts reaching for his Medicare card in his wallet. Okay. So the initial enrollment period for Part D is the same as everything else. That same 7 months. 3 months before, the month of, and 3 months after. When can I join or switch? It's the same as with Medicare Advantage. Enrollment period, Medicare disenrollment, or I have an SEP. Special enrollment periods. Permanent move out of this area, lose other creditable drug coverage. Employer, I was covered in my spouse's plan, I'm 68, she's retired, I'm losing that coverage. You weren't really told that your other coverage wasn't credible, so people can file an appeal. If I enter, live at, or leave a long-term care facility. So in other words, if my mom was 85 years old, plan, and then she is institutionalized, ends up going into a skilled nursing home for Alzheimer's or whatever, a long-term care facility automatically opens up an SEP able to change drug plans. Why? Because chances are there was a dramatic change in health, and so it's from the Medicare level people can do that. Do I want to go trolling for Part D plan sales for people at the nursing homes and that? No, I don't. But I want a Medicare subject matter expert. And if I get a call from a family member, if I have a Medicare client who's 65, could they actually have mom or dad in their late 80s in a skilled nursing home? If I can provide quality guidance to them on some of these things, I demonstrate my subject matter expertise, I become more referable from the 65-year-old children that are taking care of 80 and 90-year-old mom and dad. That's why I want to know some of these things. That's why I want you as agents to know these things. And they about extra help, state pharmacy assistance programs. So in Missouri, if you qualify someone for Missouri RX, they get SEP, they can change into other plans, and you can sell them a Medicare Advantage, review their drugs, so on and so forth. 5-star enrollment period, so if you have a 5-star drug plan according to Medicare Plan Finder, then they can switch at any time. See on the drug plan, on Medicare's website, low performing star ratings. So I had a conversation with an agent the other day. We were talking about Care Improvement Plus, Medicare Advantage plans with prescription drugs on the Missouri side. Care Improvement Plus, since United Healthcare bought them out, have fallen below 3 stars. And if Ms. serves me correct, at the end of this calendar year, it would have been 2 years going on 3. So low performing star rating status is something that people need to be aware of with IP on the Missouri side. So what does all this mean? It means the Medicare beneficiary get a letter from CMS, not the plan, not IP, saying, you know what? Your plan has prescription drug and the rating was less than 3 stars for 3 years in a row. You, Mr. Beneficiary, now have a special enrollment period where you can leave this crappy plan and join a higher rated plan. So why is this a big deal? Why am I making a big deal about it? Do I want to take a risk on selling Care Improvement Plus in Missouri if Care Improvement Plus doesn't get their star rating up for 2016? No, it's very potential that months later, my sale, when I still have a full 6-month chargeback, that customer could get a letter from CMS saying your plan plan is poor performing, switch to another one, here's an SEP. About that when you're doing your strategies. Part D enrollment penalty, again, higher premium for people who don't Part D, do not have credible coverage, do not have extra help. When they have an enrollment period, generally at the annual enrollment, they pay a penalty for as long as they join a Part D plan. 1% of base beneficiary premium. And this is a benchmark set by CMS every year. So the $30.13, that is based on the benchmark, and it's 1% for each full month eligible and not enrolled, and the amount changes every year. Okay? So, I have IRMA. I make money. I make too much money. I don't like the fact that I have to pay more for my Part B, but I do it anyway, and I said I'm not going to pay more for a B plan. So I don't, because I don't put generics and who cares and yada yada yada. Well, my IRMA, plus I end up with a 1% late penalty if I change my mind 5 years down the road. Anyway. And it recalculates, and if Medicare increases the benchmark, then my penalty increases along with that. Here's a Part D penalty example. Ann didn't join when she was first eligible by June of 2012, and she has no drug coverage from any other source. She joined her drug plan during the 2014 open enrollment. That began January 1. She was without credible drug coverage from July 2012 to December 2014. Her pay in 2015 is 30%. Because she was without drug coverage for 30 months. So 30% of the $33.13 is $9.93. Rounded to the nearest 10 cents. So she's going to be charged $9.90 each in addition to her plan's premium. So keep in mind that Medicare rounds to the nearest 10 cents when you're doing pending calculus. Yes,
And for new agents, a lot of people think it'll be just for 1 year. It's for the rest of your life.
For as long as you're enrolled in the Part D plan. The only way you have a late enrollment penalty is to die or to disenroll from the Part D plan and say, screw it, I'm going to pay all my costs myself. But here's the thing. Even at a 70% enrollment penalty, I'm paying 70% of $30. What is that? $27. For some people, is that a big deal? Sure. Yeah. For average consumer Medicare beneficiary, if you don't know, folks, even if you had 100% penalty, it's 100% at $33. Oh, you spend more than that on the casino once a month. You know, whatever. Anyway, just understand. Just understand.
Where they have a Model T golf cart.
Yeah. Okay, so I go 1 month without screen fees. So now let's check. Life events that allow special enrollment period don't include things that don't trigger an SEP. I want Danielle to answer this question. So, Lou and Jane do not blurt out. Danielle, what did not trigger an SEP to change my drug coverage?
I think C or D.
Good choice. The answer is D. And if you read it closely, it says you enter, live at, or leave a hospice facility. What is terminally ill? Hospice is usually care at home. Okay, now like that matters. But what happened if I were to enter or live at or leave a nursing home, an institutional care? That would be an SEP. Okay? program again, low income subsidy, extra help, give benchmarks. Again, I will email this out, make this available, qualifying for extra help, because we've already touched on this. This is important because it talks about automated and facilitated enrollment, okay? So, sometimes you'll hear me talk about auto enrolls. So, we have full Medicaid benefits. If I do not pick a Part D plan, I can be automatically enrolled into a Part D plan whether I want one or not because of my Medicaid status. Okay? Enrollment is based into a Part D plan that's below that Medicare threshold, that $33.13 that's used for the Part D penalty. If I'm in full Medicaid, Medicaid pays my Part D premium up to that benchmark. So anything above that, I have to pay myself. If I'm automatically enrolled and I'm on Medicaid, if I pick a plan, I'll be auto-enrolled into a plan in my area that the premium is below the $33.13. Additionally, people on Medicaid say, I like that plan, I want to pick another one. Or agent might tell the person on Medicaid a Medicare Advantage plan with prescription drug coverage. Every year, Medicare recalculates premiums and benchmarks. And it's possible that your Medicare Advantage client could be auto-enrolled based on their Medicaid status in different Part D plans every year. If that happens, client just has to reapply for the Advantage plan. So I have to troll for the Medicaid people because there's all kinds of different layers of the onion. But just know if you see a chargeback or if you don't see a renewal on a Medicare Advantage and or Part D plan on somebody that you know is Medicaid, it's because they left the plan voluntarily. They could have been auto-enrolled. Okay? And you see there are other categories where people can get an automatic enrollment or facilitated enrollment based upon qualifying for Medicare Savings Program, SS, supplemental Social Security benefits, extra help, and so on and so forth. Health co-pays. If I get help based upon being institutionalized, I have no copay for Part D drugs. If I'm reading home and community-based care services, no copay. But you get people that get confused. I'm talking to somebody on a spend down. And I'm talking to somebody on a spend down, and they have, they tell I'm only paying $2.65 for my generic drugs, $6.60 for my brand name. That's one way for me to know they're on extra help and they've got a spend down. If you're talking to somebody and they don't know what their level of Medicaid is, but they tell me they only pay $1.20 for generic and $3.60 for brand, then I know at the highest level they're generally going to be a full Medicaid benefit or something type of thing. Part of help, they're paying a little bit different qualifying structure here. I need to
Coverage on Part D, cover when, because something recently that was just opposite of what I thought. How much of the money, when the person is paying their amount before they get to the coverage gap, 100% of the money counts towards, so in other words, the total list price of the drug, if the drug's $50 and they pay their copay of $10 or whatever, the drug and the company or whatever the plan, so $50 goes towards it. What happens in the although I read something in one of these exams that we took that alluded to the fact that only the money the beneficiary is paying goes towards it, and not the list price. So I wasn't aware of that. Was under the impression it was the same in both.
Great question. I'm gonna find it for you.
Okay.
In Medicare review book. So a good question, Lou. Here is page 101 of the 2015 Medicare review. I think I got the wrong damn page. Okay. I want page 102. Okay. These items all count towards you getting out of the coverage gap. Yearly deductible if you paid one, co-insurance, and co-payments. The discount you get on covered brand name drugs in the coverage gap, what you, the Medicare beneficiary, pay in the coverage gap. Okay. What you see that was not listed up there is, to me, what popped out is the discount you get on covered brand name drugs. Does it say the discount you get on generics?
No.
Okay, so discount on generics does not count towards their troop, and in some cases, a Medicare beneficiary might be charged a dispensing fee, $3, because when they're in the coverage gap, okay, the law says the manufacturer has to pass on the discount to knock that brand name down to 45% of the cost, okay? But the pharmacy can still charge a dispensing fee. So the dispensing fee does not count towards their truth, even though the discount they got on the covered brand name drugs does. It just makes it more of the confusing, backward, upside down Greek. That's why I took the time to find page 102 of 2015 Medicare and You, which you should have with you on every opportunity to speak to your Medicare beneficiaries. Why? Because you know you're giving them correct information. They know they're getting correct information. If the information you give them fix what another agent pulled out of his hat, shall we say, who's the beneficiary going to trust and have greater confidence in?
Guy with the book.
Guy with the book. And if they have their own, are they going to pull it out and highlight that and circle the page and dog-ear it? Yes. That's why I beat this into people's heads. Carry the Medicare and You. Start learning these pages, learning the sections, read the dumb sections, and go on. You ask your friends at dinner, you will win more referrals because you become more referable.
Oh, yeah.
More opportunities. You never know who you're talking to might be the decision maker for a community organizer event, for a church group, for the whatever at the local hospital. It says, you know what? This guy, gal really knows what they're talking about, and they show me out of the Medicare and You, and they've never told me wrong, and I've referred tons of people, and they've never been told wrong. We have so-and-so do our talk for 500 people that are coming in, whatever like that. You never know when those opportunities happen. I got invited to do a talk for 200 Sprint retirees. Why? Because I got referred to the HR people from somebody else that I'd done a lot of work with and demonstrated subject matter expertise. Okay, and let me on my bandwagon, I'm going to get off of that. Okay. Changes extra help, somebody loses their extra help, have an SCP. This is all about boring stuff I don't want to go into, auto-enrollment, so on and so forth. Yeah, we're pretty much done with that. Choosing plans, that's all boring stuff I don't want to go through. Dose of change. This is important to keep in mind, especially for new agents. All Medicare drug plans must send an ANOC annual notice of change to members by September 30th, okay? So if I have a Medicare drug plan, if I have a Medicare Advantage plan with drugs, that client is going to receive an annual notice of change notice every year. It is big and bulky, it is the size of a small phone book, and it is hard for me to read, and I've been doing this for a long time, okay? So when your clients get this, chances are they look at the first page and they try to determine did the premium change, and that's all they do, okay? What you need to prepare your clients for, how to demonstrate your subject matter expertise, and how to further demonstrate referability. Folks, when you get your ANOX, it's going to tell you are there formulary changes. It's going to tell you if there are changes to premium and cost sharing and all that type of stuff. And more importantly, folks, I'm in touch with you. Every year, I just sent out sample letters that people could send out to their clients. Send them to your Part D onlys that go with your med subs. And view their benefits, make sure their drugs are still covered, make them look through their big, thick ANOC, provide service, be referable, even if it's just on a $50 Part D commission. Chances are you sold them a med sub to go in with it. Chances are if you do that service, you'll be more referable to their friends that want med subs as well. Oh, this is appeals, coverage determinations, it's all on drugs. Time frames. Some people will say they need a drug, maybe they need an exception. It's mid-year, they've had a health event, they need a drug that's not on their formulary, okay? You, your prescriber, can request an appeal. Yes, standard within 72 hours, you also have expedited, okay? So if somebody's calling you and it's like, man, I really need it, you know, folks, we need to do an expedited appeal, and that will be an answer within 24 hours, okay? We have exceptions, formulary exceptions, drug non plans formulary or access requirements. They want an exception from step therapy, they want a tier exception, they need to get supporting statement of the doctor, they make their request, and the exception may last a year, and then they may have to review. There are appeals on Part D, and it talks about that process here. Here's the flow chart. Even I don't understand this, I'll be honest with you. I just don't, and I don't run into a whole lot. So different things here, and of course the resource guide, and that pretty much wraps that up. Yes, Lou?
Another question on drug exceptions. I understand drug exception if somebody is diagnosed with something in the middle of the year and it wasn't a drug that they ever thought they would be taking. And unfortunately, their formulary with their Part D doesn't have it. They can ask for an exception. They can't knowingly go into a plan knowing that it didn't take it and then ask for it, right?
Correct.
Okay.
Correct. All right, we're going to have a little bit of fun here. I'm just going to take you through some scenarios. All right, so we've done, I take that back. So let's put this all together, okay? I'm an agent now, and I'm a new agent, so I've got all these Medicare options. I've gone through all this stuff on Part D till my brain hurts, cover gap, all this other stuff. What does it mean? How do I break it down to simple English for the client? It's all a puzzle piece. So 2 ways to get your Medicare coverage. The reason there's a line down the middle here is because I'm either on one side of the line or not both. So the average client that's approaching Medicare age, I'm either doing option 1, which is to enroll in original red, white, and blue Medicare, Parts A and B, pay my Part B premium. Decide if I want drug coverage, enroll in a plan, pay the premium. Decide I want Medicare supplement to help with Medicare's deductibles, pay the Med premium. So I have a card and a premium, card and a premium, card and a premium. This is great. I buy a med sub to go on with my A and B. I don't have any networks. I only have very little, if any, out-of-pocket expense, but I have big premium. Okay? My option is the or I can do an Advantage plan. insurance companies provide it. I've got my coverage for A, B, and my prescription drug in one card. I have my Part B premium, the plan may charge me a premium. I have to be happy with the networks. Usually it's an HMO or a PPO, and I want to make sure doctors and hospitals are in the network. But I like an Advantage plan. And if the plan works for me, I don't need a separate card here. I don't need a Medicare supplement. So instead of paying a card and a premium, card and a premium, card and a premium, I have one card, I pay my Part B, and that the hospital, the doctor, and the prescription and the pharmacy.
Could you get like this? You print it off?
Actually, no, you cannot print your own page off because you're creating marketing materials that have not been approved. But notice down here at the bottom it says page 17, Medicare and You publication. Seeing that Daryl would refer to the Medicare and You, so I go to my 2015 Medicare and You book, and it's on page 17 of the Medicare and You. Here's a little thing that I just put in that slide. There are two ways to get your Medicare coverage. Decide if you want Medicare A and B.
You can show like that page, you just have it, you just can't give it to them.
No.
You can't.
No.
Okay.
Because that's unapproved marketing material.
Okay.
But I can open up my Medicare and You, show them page 17, which is exactly the same thing. I put it into the PowerPoint so I could put it all on one thing so you could see it rather than going here. Always use your Medicare and You. Folks, here's how it works. I can do one or the other. What does it say down here? If you join a Medicare Advantage plan, you use Medicare supplements to pay your out-of-pocket. If you already have a Medicare Advantage plan, you can't be sold a Medigap policy. Use a Medigap policy if you disenroll from your Medicare Advantage plan and return to original Medicare. So everything you need to know to keep you compliant, to keep you out of trouble, is where?
Page 17.
It's in you. It's all over the place. This subject matter expert, be referable. All right.
And for future generations listening to this video, they go to Medicare.gov, right?
Stop. Where you're goofing stuff here. I don't want to do that. All right. So we're going to take a look at option one, Medicare supplements. Okay. So my Medicare supplements, again, this is the standardized chart. It's where in Medicare and You booklet, or it's all in your guide to shoppers to health insurance for people with Medicare, the MedSup Buyer's Guide, but which is the standard premiums, and again, are the standard designs. So these are all the gaps of Medicare as defined by Congress, and so the various different plan types of supplements, most common being F. Why? Because it pays 100% of all the leftovers of Medicare. The one that's very common and getting more ground is Plan G. Why? It does everything that F does except the Part B calendar year deductible of $147. So why do people do a Plan G instead of an F? Because in many cases, the cost difference is $200 or less in premium or more. In some cases, you buy a Plan F for, let's say, $2,000 a year. And a Plan G, depending on spousal discounts and carrier and their zip code, may only be $1,600. Well, I can save $4 in premium to self-insure $150, and even if I pay the Part B deductible for that calendar year, $150, I still save $250 a year. Sign me up for that. So another reason to talk about Plan G, MedSups, Aetna MedSup has been very good on G. Mutual Omaha has been very good on Plan G. Aetna's getting ready to, Aetna's MedSups is getting ready to lower rates on Plan G in Kansas by 15% for September 1 effective date. So another one. Anyway. anyway, so those are the common types. Medicare policies typically increase with age, guaranteed renewal by law, are all standardized, do not include drug coverage, so someone needs to enroll in drug coverage separately. Again, our guaranteed issue when applying within 6 months of first activating Part B coverage of original Medicare. At that period of time, your clients must answer the health questions when applying to determine their coverage. There can be some exceptions to that. Carrier can use the answers to questions to decline or increase premiums. Now, from an agent standpoint, I activate my Part B at age 65 because I'm nervous. I'm sure I've got everything. But I'm still employed, covered by my employer group plan, and I'm on that till I'm 70. So I have 5 years I've had my Part B, A, and employer group. Because I have cancer. Can I get a med sub to answer health questions? Yeah, because that's a loss of employer group health. It is guaranteed issue on med sub. But notice, I'm talking about open enrollment within 6 months of applying for Part B. Why is this different? Why is Daryl making a big deal about this for agents? It's simple. Reach and educate your turning 65 people that approach you, maybe are working. Show them page 25 of the Medicare News as if they're working for, they have coverage through their or their spouse's active employment, they may want to delay their Part B. Why? Because if I'm 70 years old, been working since age 65, and I've had employer group coverage, and I did not enroll in Part B at age 65 because I was educated. Now I have cancer, I'm disenrolling, or I'm leaving my employer group, and now enroll in Part B of Medicare. 6-month open enrollment for MedSup starts when I activate my B. My agent can enroll me in a MedSup. No questions, my cancer's covered, life is beautiful, and my agent gets paid 100% commission on that MedSup sale. However, if I was nervous at age 65, I enrolled in Part B just to be safe, and I had my employer group. At age 65 and 6 months, my open enrollment for the MedSup, based on activating Part B, expired. But at age 70, because I'm in my employer group, I've retired because of my full-blown cancer. When I use Medicare and I want to buy a MedSup, I can still get the MedSup. The agent can still sell it to me as guaranteed issue, not open enrollment based upon Part B. What's the difference of the agent? Commission. Guaranteed issue on most supplement carriers is 50% of normal commission, or in some cases, none whatsoever. So I beat this into my client's head, everyone I can talk to, because I have no idea who is going to get a health condition down the road, and yet I'll do the right thing for the client, and I'll sell them the MedSup guaranteed issue for lower commission. If I can make them not be nervous, number one, what did the client do for 5 years?
You paid Part B premium.
Paid Part B premiums that he didn't need to. So on 5 a year, that's $1,200 times 5 years, he overspent $6,000. He could have given that money to me, and I could have gone to Mexico every year. Yes, sir.
Either employee plans or retiree plans, when somebody does turn 65, that it seems like there are some that offer you a price on your insurance premium.
is different than active employment.
Okay.
Okay, we'll need to go to that here in a minute, okay? So I'll keep everything on the slide and try to avoid these side conversations without slides. I want to do that. Okay, so Medicare policies basics, again, no networks, okay? I don't like Medicare Advantage because I don't like having to pick my network. I just want to go to any doctor, bingo, it's a med sup plan. No authorizations, no referrals. As long as the doctor bills Medicare, that med sup will pay. And it pays automatically. The client doesn't have to submit a bill. It's all billed by the Medicare program because you put the client's Medicare ID number on the med sup application. It goes into the computers. Medicare gets the claim. Medicare uses it. The balance automatically goes to the med sup carrier. Okay. So it's typically the largest monthly plan premium, and it's prepaid convenience. I'm paying $8 a month for insurance when I was under 65, so now I pay $150 for a supplement and $105 for B and a Part D plan that adds up to $300. That's bargain. I got $500 a month more in my pocket. Okay? You need to understand Medigap pricing. Most plans are attained age rating, which means that you pay the premium based upon the age you attain. That would Kansas model. In Missouri, we have entry age or issue age. And this is important because when I'm 65 and I sign up for a med sup, in the state of Missouri, the premiums at 65 are a lot higher than they are on the Kansas side. And that's because that client will always be charged the 65-year-old premium even when they're 75 by that carrier. So in other words, I give you a Mutual of Omaha Plan G at age 65. Now 75, Mutual of Omaha is charging people that are new to Medicare age 65 10 years from now. That's what I'll be paying. Okay? So some people get freaked out, or some Medicare members think, well, I'm issue age because that's better. It's better to begin with because they know it's going to catch up to you, so don't let people weird you out on that. So now option 2, the Medicare Advantage. Again, typically the lowest premiums, includes the Part D drug built in. They are going to have a network, HMO or PPO. Chances are very good that they're going to have prior authorization, meaning they have to have their doctor get permission from the HMO plan and may need referrals. Always coverage for emergency and urgent care, and I make this section the page to the left. My words are escaping me. A footnote there for page 75 Medicare and You where you can find that. Benefits and premiums do change every calendar year on Medicare Advantage. It is a pay-as-you-go plan. You have co-payments and co-insurance with an out-of-pocket limit. Medicare plans pay money, or Medicare, pays plans money every month to provide care to Advantage Plan members. The plans must follow Medicare's rules. And you will find that on page 75 of the 2015 Medicare and You. I tell client agents, for billing purposes, the Medicare Advantage card is the member's Medicare card and the only card they present. And you can change Advantage Plan company's 3 annual open enrollment period with no health questions or pre-existing. And here's page 76 of the Medicare and You, and what does it say up there? This is where you take them. Medicare pays a fixed amount for your coverage each month to these companies offering Advantage plans. These companies must follow the rules set by Medicare. Okay, you can only find if you have it available in the area. So people that live outside of the Kansas City metro, maybe they live up in Atchison, maybe they live up in St. Joe, they may have very limited choices in Buchanan County or some of those other counties. Okay. So enrollment periods. Now, if I go back to the very beginning, and I'm going to do that here real quickly here. My options. I said, how do I tie this together? How do I help people understand? Folks, it's real simple. I'm going to do option 1 and have a card and a premium, card premium, prepaid convenience, no network, but I'm paying on average $200 a month for my supplement and my Part D, over and above what I pay for Part B like with Medicare, okay? If I join an Advantage plan, we still have 0 premiums. So the question that you pose to your client is, do you rather have the simplicity of a fixed budget item in your premium every month and know that you don't have to worry about co-pays very much, you don't have to worry about networks, or are you happy with network plans? And if they don't overcharge you $200 every month for your supplement and your Part D, and you have that money in your checkbook, is money that you don't pay in premiums more than enough to offset for having to put up with the network and having the co-pays come out of your pocket? Like most people, if you say, well, I could pay an awful lot of co-pays with $200 a year in premiums that I don't spend on a supplement and a Part D, and even pay $500 in co-pays in a year, that's still $1,900 less. So it depends on the client. Anymore, I'm kind of digging selling med subs because I don't have to do the annual enrollment shuffle with them every year. But let's face it, everybody can't always afford a sub. Okay. So enrollment periods. Now I want to look at scenarios to tie up the learning and keep us under our 3 hours here. So what scenario? The scenario is, it's March 2nd, Bob is 68 years old, retired, and has employer coverage through his wife, Carol's employer, since he was 65. He has Part A, but he does not have Part B, and losing employer coverage on March 31st due to his retirement. So Carol's going to work anymore. There's no more of employment. 65 in April and plans to enroll in Medicare. What should Bob and Carol do to ensure no interruption in their coverage?
Enroll in Part B. You need to enroll in Part B. She needs to get signed up for Part B and figure out what do they want to do. And it could go into effect April 1st as long as they get their application submitted before the end of March.
Yeah. Bob will need to enroll in Part B. Carol will need to enroll in A and B no later than March 31st. Hope they don't wait that long, but technically they could wait till March 31st and have coverage on April 1. Social Security Office facilitates enrollment paperwork. Bob will be asked to have Carol's employer verify his coverage in order for Bob to enroll in Part B with a enrollment period and avoid late enrollment penalties. So you always want to fill in all the blanks to your customer. Folks, you're going to have to take some forms to your employer to fill out that say, yes, we have these coverages, and that's why we're enrolling late in some cases. Once they're all applied for their A and B, they can shop for drug coverage, supplemental coverage if they want. They also choose to evaluate Medicare Advantage with Part D if it's available where they live. Mary, 74 years old, very little medicine, 2 generic high blood pressure pills that she can get for less than $4 a month. She's never in a Part D drug coverage since she thinks she's and she's just had a cardiac event. Now doctor is prescribing 2 brand name medicines that cost over $400 a month for her heart condition. What happens now? Well, this May, his next chance to enroll in a Part D plan is October 15th through December 7th, the annual enrollment period, coverage effective January 1. So I have to pay 100% for her 2 new medicines, or see if she can get manufacturer assistance, which is usually based on income. Should she decide to enroll, and when she enrolls in a Part D, she will also be subject to a lifetime late enrollment penalty of 1% for each month she was eligible for Part D, but not enrolled. So that all being, I rounded things to make it simple, but we said was 74. So she's been without drug coverage for 9 years. So 9 years times 12 months is 108 months that she was eligible for but didn't have. So she paid 100% LEP enrollment penalty applied to the benchmark. She's paying $35.78 or actually $35.80. I should have rounded that up to the even cent on of her Part D plan that she selects. So the result is she has a late penalty, she'll pay all her medicine, and she won't be able to get coverage till January 1. Assuming that she does enroll in a Part D plan, she has that LEP for the rest of her life. Dick and Sharon are new to Medicare at age 65 and are federal employees eligible for retiree benefits. That's the coverage offered by her retiree plan, and since it comes with a substantial premium and offers medical coverage for doctors and hospitals as well, decides not to enroll in Medicare Part B. After all, she has been very satisfied with her employee coverage while working and doesn't want to pay Part B premiums in retirement. So what's on here? Is Shirley still working? No. There's no active employment. Since both are really healthy and don't like doctors anyway, 18 months passes before Shirley sees a doctor. Days later, she gets a bill from the doctor saying Medicare denied her bill, and so did her retirement plan. She confused as to why her insurance denied. Can you guess what Dick and Shirley did wrong and how they corrected it? Page 28 of the 2015 Medicare and You states that retiree coverage on Medicare is considered secondary, and Medicare Part A and B are primary. Dick and Shirley do not have Part B coverage for doctor visits. They rejected their claim due to no coverage. And since Medicare rejected it, the retiree coverage has nothing to be secondary to. Take a look at that in our what? Medicare and You, which we carry with us on every appointment. Enrollment period. Down. General enrollment period, special enrollment period. I put the wrong page on there. Page 26. Okay. Conciliated coverage and retiree health plans aren't considered coverage based on current employment. You are not eligible for a special enrollment period when that coverage ends. So let me back up a little bit. I thought I had the right pages in here. What we're talking about is this. Should I get Part B? An employer union coverage if you or your spouse is still working and you have health coverage, it may be to your advantage to delay Part B enrollment. But it also says right here, COBRA and retiree health coverage don't count as current employer coverage. See page 28 to find out how it works with Medicare. So the critical thing is, once employment or coverage based on current employment ends, three things happen. You have 8 months to sign up for Part B without a penalty. It will run whether or not you choose COBRA. So like this applied to Channing's case that we talked about the other day. If you choose COBRA, don't wait until your COBRA ends to enroll in Part B. You don't enroll in Part B during the 8-month period after employment ends. You have to pay a penalty if you enroll for as long as you have Part B, and you won't be able to enroll until the next general enrollment period, and have to wait until July 1 of that year before your coverage begins. This may cause a gap in your health care coverage. Okay? So we're talking about with some other things here. COBRA retiree. And page 28, how does other insurance work with Medicare? If you have retiree insurance, insurance from your or spouse's former employment, that pays first. If you don't have Part B and you have retiree or COBRA, you got a world of problems without Part B. Okay. So back to Dick and Shirley. Well, here's what happened. As you or your spouse must be actively working in order to delay Part B enrollment while covered under employer group insurance. Employees with 20 more employees, insurance coverage is considered primary to Medicare. Retirement coverage, while many times is quite good, is not based upon active enrollment and generally requires the member to be enrolled in Part B. Since more than 8 months have passed, they had employer coverage through active employment, the SEP has expired to enroll in their Part B. Dick and Shirley must now wait for the Part B general enrollment period, January 1 to March 31. To enroll in Part B, each pay a late penalty, 10% added for each full year, and their Part B of Medicare won't start until July 1. So Dick and Shirley's Part B coverage won't be effective until July 1. They have coverage for outpatient services, doctors, labs, x-rays, all that, until July 1 as well. Now, if you're thinking I'm pulling this out of my ass, this scenario is very personal to me because Dick and Shirley are my mom and dad. It happens all the time. Talk to clients, make sure you do a good job. Be a Medicare subject matter expert. Actually use Medicare and you in every presentation and show people every time. Folks, runs through. Entry to form, I did manage to keep it under 3 hours. So hopefully good, and hopefully this recording is actually